Benign Prostatic Hypertrophy by Judith Garcia. In this presentation, the following contents will be discussed: normal physiology, pathophysiology, clinical manifestations, evaluation, and treatments. Normal physiology. The prostate is a walnut-sized gland located between the bladder and the penis, just in front of the rectum. The urethra runs through the center of the prostate from bladder to penis, letting urine flow out of the body. The prostate has three zones: transition, central, and peripheral. The prostate surrounds the urethra, and this area is called the prostatic urethral area. The prostate is composed of glandular alveoli and ducts fixed in fibromuscular tissue. Androgens and androgen receptors regulate the growth, development, and function of the prostate. The prostate secretes epithelial secretions. One of those secretions is called the prostate-specific antigen, or PSA. These secretions contribute to the ejaculate. Pathophysiology. Benign prostatic hypertrophy, or BPH, is also called benign prostatic enlargement, or the most common name, benign prostatic hyperplasia. The enlargements are due to nodular hyperplasia and glandular cells hypertrophy. Transition zone is the one affected, which is the periurethral glands, or the inner glands or layers of the prostate. Due to the enlargement, it compresses the prostatic urethra, the results of which are a spectrum of lower urinary tract symptoms. There are several causation factors implicated in the development of BPH. Number 1, levels and ratios of endocrine factors. Androgens is noted to create growth-promoting and tissue remodeling microenvironment in the prostate. Estrogen, on the other hand, promotes or inhibits prostate proliferation. Number 2, there are changes in the balance between autocrine, paracrine, growth stimulatory, and growth inhibitory factors. Number 3, dihydrotestosterone, or DHT, which is necessary for normal prostatic development, has a role for BPH that is still unclear. Number 4, there is a relationship with aging in the development of BPH. And number 5 is the remodeled microenvironment. Benign prostatic hypertrophy has a relationship with aging. At birth, it is pea size. Until puberty, it gradually grows, and then on the third decade of life, it rapidly develops into an adult size. However, at 40 to 45 years old and older, benign hyperplasia begins and continues to grow slowly until death. Remodeled microenvironment. As an interaction of factors 1 to 4 that lead to the increase in prostate volume, a remodeled stroma results, which promotes local inflammation that alters cytokines, reactive oxygen or nitrogen species, and chemoattractants. This increases oxygen demands of proliferating cells, and local hypoxia results that induces angiogenesis and changes to fibroblasts, the results of which is that of functional and phenotypic changes of fibroblasts to the myoblasts, which is called transdifferentiation, and this is the hallmark of the remodeled microenvironment of the prostate. The following are the clinical manifestations of benign prostatic hypertrophy. As a result of increased nodular hyperplasia and cellular hypertrophy of tissue that surrounds prostatic urethra, these lead to urethral compression. A spectrum of lower urinary tract symptoms results among 40 to 70% of men with BPH. Chronic inflammation and pathologic examination may also present. The following are the symptoms of lower urinary tract symptoms. Initially, there's an urge to urinate often. There's delay in starting urination. There's decreased force of urinary stream. And after several years, bladder emptying challenges happen. Increased volume leads to long-term urinary retention as well. And further progression would result in volume that causes uncontrolled outflow incontinence with increased intra-abdominal pressure. There's a significant decreased force of urinary stream and an increased time to initiate and complete voiding. If BPH is not addressed, the following complications may result: hematuria, bladder or kidney infection, bladder calculi, acute urinary retention or hydroureter, hydronephrosis, and renal insufficiency. Evaluation of BPH. So number 1, the medical history of the patient should be taken. Number 2, physical examination should be performed with digital rectal examination or DRE that would help us determine hyperplasia. DRE is annually done for 40 years old and above, and it should be sooner for high-risk men. The findings would show soft or firm enlargement with smooth mucosal surface. No discernible distinction between lobes, and asymmetry is common. It does not always reflect degree of BPH, since the substantial portion of enlargement is intravesicular. Number 3, order laboratory tests, which are the following. Prostate-specific antigen, which may be increased in BPH and prostate cancer. Urinalysis, which includes serum creatinine, BUN levels, uroflowmetry, phosphoid residual urine, pressure flow study, cystometry, and cystourethropy. Number 4, the following procedure can also be ordered. Transrectal ultrasound, which will determine bladder and prostate volume and residual urine. The following treatments may be indicated for BPH. Number 1, medications. Alpha-adrenergic blockers like prazosin and tamsulosin. They help relax smooth muscle of bladder and prostate. They do not affect PSA level, and there's no effect on cancer risks. Anti-androgen agents like finasteride or Proscar. They selectively block androgens at prostate cellular level and causes the prostate to shrink. They improve BPH-related symptoms and reduces urinary retention symptoms and BPH-related surgery. Number 2, minimally invasive procedures, which is focused on hyperplastic tissue removal to prevent urethral obstruction, like interstitial laser therapy, transurethral radiofrequency procedures, cool thermotherapy, prostate artery embolizations. And then number 3, genetics. There are certain techniques in genomics, proteomics, epigenetics, discovery of aberrant signaling pathways, novel biomarkers, DNA methylation signatures, and potential gene-specific targets are being developed in order to address BPH. And number 4, a permanent indwelling catheter will be inserted if the patient is unable to tolerate surgery.